Hello everyone, welcome to my YouTube channel. This is Dr. Naz and today I'll be discussing about Clostridium difficile infection. So Clostridium difficile is a gram-positive rod and it is the most common cause of antibiotic associated diarrhea. Clostridium difficile can produce two types of toxins, toxin A and toxin B. So the symptoms usually begin in the first week of intravenous antibiotic therapy, but they can occur at any time within the 6 weeks. There will be sudden onset of abdominal pain and profuse watery diarrhea, and WBC count will be raised. WBC is white blood cells. Pseudomembranous colitis can also occur, which include all the above symptoms along with formation of pseudomembrane on colonic mucosa, and there will be bowel wall thickening due to severe inflammation of the large intestine. So as you can see in this picture, there are raised yellow-white plaques that coalesce to form pseudomembrane, and this occurs after the use of antibiotics. So fulminant colitis can occur in 2 to 3% of patients affected by Clostridium difficile, and it presents with toxic megacolon, that is colon dilation will be more than 6 cm or 60 mm on abdominal X-ray. There will be systemic toxicity and there can be bowel perforation. Dilation of colon is clearly appreciated in these pictures. So if the patient is symptomatic, then we will go for detection of Clostridium difficile toxin A or B in the stool using ELISA. Stool PCR can be done, which is a quick test and it is becoming a test of choice. Alternatively, we can perform the test which contains two methods. In step 1, we will check glutamate dehydrogenase enzyme by immunoassay, and in the second step, if there is the presence of enzyme, then we will check cytotoxin assay. Sigmoidoscopy can be performed and it will show erythema of rectal mucosa along with white plaques and adherent pseudomembrane. So after the diagnosis is made, we have to stop the precipitating antibiotic and patient should be isolated. Supportive therapy including IV fluids and resting of the bowel is often needed. In mild to moderate infection, oral metronidazole is given 500 mg 3 times a day for 10 to 14 days. What are the indications of mild to moderate infection? Your white blood cell count of the patient will be less than 15,000. Creatinine level will be less than 1.5 times baseline, and if age is less than 65 years and there is no sign of peritoneal irritation. In severe infection, oral vancomycin is given for 10 to 14 days or IV metronidazole can also be used. What are the indications of severe infection? WBC count will be more than 15,000. Serum creatinine will be 1.5 times baseline. Age will be more than 65 years and there will be signs of peritoneal irritation. So in recurrent infection, in the case of first relapse, oral metronidazole or oral vancomycin should be given for 10 to 14 days. In case of second relapse, oral vancomycin should be given, which should be tapered for 6 weeks. And if there are more than 2 relapses, then vancomycin tapering dose along with adjuvant therapy, which includes probiotics, rifaximin, which is a broad spectrum antibiotic, nitazoxanide, which is an antiprotozoal, and fidaxomicin, which is a macrolide antibiotic, can be given. In refractory cases, fecal transplant appears to be safe and effective. How do we perform fecal transplant? We have to take a stool from a healthy donor which contain good bacteria, and it is processed into pills or a liquid drug form, and then it is given to the patient either orally or through colonoscopy. In refractory cases, IV immunoglobulins and corticosteroids are sometimes given. I hope you learned something from this video. If you do, then please like it and subscribe to my YouTube channel so I get motivation to make further videos. And thank you so much for watching.